So in summary, as far as diabetes is concerned, of course, physical activity, nutrition, weight loss, and metformin, the first drug, and addition of SGLT2 inhibitor. This is the second line drug, evidence-based. I do not say that we should do it in all patients, but evidence-based, and followed by either GLP-1, DPP-4, insulin, sulfonyl type, thyroxolidine. This should be guided by patient preference. And this is what is the model which is brought by RSSDI. They talk about patient factors, and we should always look at patient's pocket and patient's money. And these are the factors which will influence selection of glucose-lowering drugs other than SGLT2 inhibitor. And if the patient has heart failure, then probably we need to avoid these drugs. If the patient has a high risk as atherosclerotic disease, then maybe GLP-1. If we want to avoid hypoglycemia, then give these drugs which can cause reduction. After having talked about blood pressure and sugar control, the third and most important factor, that was so-called kidney drug, is trying to control metabolic acidosis. I remember my teacher, Dr. Rizvi, used to give pulse soda bicarb, and we never used to understand why is he giving that. But now, a very strong evidence to suggest that by giving just a tablet of 1.5 to 2 grams of soda bicarb in a patient whose serum bicarb level is less than 22 microgram, can help him preventing the progression of chronic. And these are some of the factors. CKD progression causes increased acid load, it increases endothelin levels, it increases angiotensin level, and that can cause host lot of factors which can further progress the progression of chronic kidney disease, and also may progress. So by giving a tablet of soda bicarb, we can always try to ensure, and there have been a meta-analysis of more than 14 trials which have shown that not only metabolic acidosis is a risk factor, but when given to a patient whose serum bicarbonate is less than 22 microgram, it has shown that it has been found to be a very, very effective tool, and all the evidences suggest that this drug is supposed to be the most effective drug for intervention by a nephrologist, oral alkali supplementation, or a reduction in dietary acid intake may slow the rate of kidney decline. This is one drug which a nephrologist can claim that this is a drug which one can use. Of course, coming to the lifestyle intervention, I think it's extremely important. I'm very sure must have had a heavy and hefty dinner yesterday, and you're going to have a lunch. But more important is to your tummy, your plate should be half full of fruits and vegetables, and one-fourth of a protein, and one-fourth of a whole grain and starchy vegetables. And in terms of chronic kidney disease patient, we can have certain strategies where we can give them a low protein diet or a very low protein diet with addition of keto acids and amino acids. This has been shown in certain evidences, certain strategies to prevent the progression of chronic kidney disease. It should be lower in processed meats, in refined carbohydrate and sweetened beverages. One of the, I think I agree with one thing about Ramdev is he calls cola as a toilet water. And I also call cold drink as a toilet water. It does much more harm than actually what it does. And this was one of the study published recently in 2020, again talking about low protein diet from chronic kidney disease, 8 years of clinical experience. And they concluded that a low protein diet recommended by nephrologists in conjunction with skilled dietitian delays dialysis and preserves. So it is extremely important to first assess the dietary intake. Most of our Indian patients, I don't know about West Bengal people because you eat a lot of fish, but most of the Indian patients are already on low protein diet, so we do not need to restrict them further. Our progression should be much less. Talking about salt, now people ask me how to reduce salt, So these are some of the ways and means by which you can reduce the salt intake, and buy fresh vegetables, cook at home, avoid salty processed meats, keep healthy unsalted snacks, cut salty sauces like soya sauce, which has full of salt. Use sweet, sour, bitter, and spicy or hot flavor to season food instead of salt. Read tablets, choose lower salt brands when possible. So these are some of the strategies which can help you reduce the. Now there are certain more strategies. I don't know how much time do I have. I'll have just 5 or 10 minutes. What is the effect of ketonologues? Now again, a very, very costly drug which is being given. I don't want to name the brands, but these are given in the dose of 2 TDS. The evidence is there, but evidence is not very strong. Now, if you look at the patient's pocket, and if the patient's pocket cannot afford ketonologues, then we can at least put the patient on low protein diet And this is again the study done from India from SGPGI. They did demonstrate that it may help you prevent decline in renal function, but the evidence is not very strong. Similarly, a role of probiotics. People give a very costly probiotics to another, adding pill burden to CKD patients. Role of probiotic in CKD is not clearly defined. So as of now, the evidence is only for soda bicarb, only for treating sugars, only for treating high blood pressure, nothing else. And this was another study which was shown there was no evidence suggested that probiotics possess meaningful impacts on the reduction in the uric acid level. Now, this is the study which I was going to talk about. This study was published from Kolkata. Is N-acetylcysteine taurine a protecting agent? Nephrosafe. The drugs look so, even yesterday night, one patient texted me that so my doctor has put me on Nephrosafe. Is it really going to save my nephros? So this was the study done by your colleagues from Kolkata, and this will be published in this this May issue of API. They did show, but the numbers were very small. I have criticized this study in my editorial. The statistical tool used were very, and as I mentioned, I have clearly mentioned about my conflict. They have not mentioned whether this study was supported by the company or not. They showed that N-acetylcysteine along with pyridoxine, that is nephrosafe.
Excuse me, sir.
May be useful.
You are very late. You are very late. You have already.
Ma'am, I was told half an hour. I don't know.
No.
The last slide.
Already completed.
Okay. I still have 8 minutes. Started 12. Anyway, so these are some of the studies which have shown. The last study is on uric acid. Now, the study is again whether to give febuxostat or xyloric in such patients or not. It is still a controversial thing. And finally, what is more important in preventing the progression of chronic disease is to prevent infections. So we must vaccinate these patients. This is the strategy which is developed by Indian Society of Nephrology. All patients of CKD should receive hepatitis B vaccine, a pneumococcal vaccine, a varicella vaccine, of course, a diphtheria and tetanus toxoid vaccine. And we should always involve the nephrologists. They should work synergistically. Any patient who develops a GFR of CKD stage 3 or above should at least once be referred to a nephrologist. As the patient safety is first, don't keep the patient with you for a long time. Combine the management with the nephrologist. And this has been shown that patient safety and following CKD detection, if we involve the nephrologist, then probably the progression can be much delayed. And these are some of the standards of care for therapeutic management. As I said, there are certain newer molecules in the pipeline which can help you prevent fibrosis. We know these drugs are being used for COVID patients as well. There are certain drugs for antioxidative stress. There are anti-inflammatory drugs which are being used. There are single transduction pathway vasoactive agent and new molecule. So I think it is very important for us to guide our patients well so that finally we are able to prevent the progression of chronic. Thank you very much.